Hi, it's Dr. Lena here again. You're watching this video because you've been instructed that you are going to get a total shoulder replacement. A total shoulder replacement is necessary. It's never necessary unless you have significant pain. It is a pain control operation, number one. It is secondary to arthritis, and it could be due to osteoarthritis or inflammatory arthritis. And depending on what the condition is, we would address it with a different surgical procedure. What arthritis is, it's a wearing away of the cartilage. The cartilage space between the bones basically gets more and more narrow until it is bone on bone. And you eventually will feel a cogwheel rigidity to your shoulder. As you try and move it, because there's no cartilage there, it binds and just kind of ratchets on its way down. It is at that time, and when you're having night pain, that you should consider getting the total shoulder replacement. Not everyone is a candidate for a total shoulder replacement. It depends on what the glenoid bone stock is, because we need to have good bone stock for the glenoid to sit well so that it doesn't wear out or doesn't fail. In the preoperative planning, depending on what your glenoid looks like, we may need to do an MRI to verify whether the rotator cuff is intact, because if the rotator cuff is not intact and we do a total shoulder, it will fail. And number two, we do a CT scan so that we can do the preoperative planning for the glenoid side to make sure that the implant is put in the exact correct position so that it will decrease the chance of failure moving forward. What a total shoulder is, it replaces the ball with a ball and the socket with a socket. And so as you can see here, this is the humerus. And so when you get arthritis, you get a wearing away of the cartilage, and you also develop a big bone spur inferiorly. That big bone spur is not just a spur, it's a ridge that goes forward and it goes back. And that ridge limits your mobility. So you'll find that you have decreased abduction, internal rotation, and external rotation. And that is usually why people choose to get a shoulder replacement, so that they regain their mobility, improve their function, decrease their pain, and improve their sleep. When we do a shoulder replacement, the first thing we address is the humerus. The nice thing about the implants these days is that when I first went to practice 16 years ago, there were three sizes that fit a 350-pound individual, a 200-pound person, and an 80-pound woman. And so now we have infinite number of sizes because there's a lot of modularity associated with it, with different step-offs, different depths, different widths, and there's all kinds of different implants that we can use. I personally use the Tournier system. I think it's very good, and I think it really does the job for most patients. This is a regular Tournier implant. I currently am using the Ascend Flex, but this is an older model of it. And so essentially what we do is we cut the head off, we remove any osteophytes around the periphery, we see what your anatomic outline is of the humerus, and then we match it with a piece of metal. The majority of times we're doing this with a bony ingrowth stem, so we don't use cement on this side. When we do the dissection for this, we actually take off the rotator cuff in the front, and then we have to reattach it back afterwards. The reason I'm commenting on that is that we need to limit the external rotation in the early phases after the surgery. The reason for that is that as you externally rotate, you put stress on the subscapularis, and that can pull and can cause that the repair to fail early on. So the one thing we make sure of is that you don't do that external rotation. Once the glenoid side is correct, we then switch over to the humeral side is correct, we switch over to the glenoid side. And so the glenoid, essentially, we ream down the bone, and then we insert a piece of plastic into the bone that the humeral head will ride on. There are risks associated with this, and you can look back at the video regarding the risks associated with it, but people do very well with the total shoulder replacements. This is once again an older model. There are new models out. The Ascend Flex is one of the ones that I use most commonly. More and more young individuals are getting shoulder replacements because they're more active in athletics and in the gym, and so with that arthritis at an early age, you want to minimize the amount of bone loss. One of the reasons we switched away from this implant is because there was some stress shielding on the bone, and the bone went away. Because of that, we went to the Ascend Flex, which is a shorter, stouter stem that has better bony ingrowth throughout, and so we do get less bone loss with that. One other implant that is out, and this is the newest thing, is the Simplicity stem. So this is essentially a head with just a tri-flange that we insert into the bone, so we minimize the amount of bone that is removed, number one, so in case you have to do a revision setting, and number two, there's no stress shielding to the bone surrounding it, and so you keep the bone stock there. So for the young individual, the Simplicity stem is just a perfect augment to the Tournier system.